Good afternoon, participants and speakers, all for this online lecture series on guidelines, which is of NHSRC and DSPRUD New Delhi. Session is on safety with medications. Will be taken Sangeeta Sharma, body in ear, nose, Dr. Neeraj Narayan. Now I request sir, advisor, vision to address and themes of the series. So,
before he starts, I think few more people have joined just now. There is a pre-test link in the chat box. Please click on this and start filling, while we are proceeding with the program. Over to you, Dr. Srivastava.
And in fact, a very good afternoon. And for commitment for improving the care at the most peripheral apex level. And at the outset, we are extremely to Professor Mathur for having taken time out of his schedule at Amrita Hospital, School of Medicine, to be with us towards problem which we all of us must have seen, and at times the outcome of actions could be disaster at least. And side, just to give it in the things in the correct process, supplements have been made in the improving the infrastructure situations. But we will better health outcomes. Our patients get what they deserve. The correct protocol. Prescribing does not rational use of antibiotics is made. And in this, we are extremely grateful to have partnered with Society for Promotion of Drug, led by a very dear colleague and friend, Professor Ma. This series of the lecture launched. I will talk about contemporary topic pertaining to the prescribing. Second part, the speaker normally talks common relevant problems relevant at every, whether at that level, at the second tertiary level, because potential emergency all of us may encounter. In this, since I come from background, I still recall
Sir, you've become mute ho gaya, sir.
I mean, from our side, it's okay, but I don't know.
And a lot of noise is also coming, some cracking noise is also.
Just put off one. Just a minute. Now is it audible?
Yeah, it is better now. Yes.
I've just now narrowed on the speaker only, nowhere else. So what I was talking about, the relevance of the problem, that foreign body, that when like post-independence, Air Marshal Subrat Mukherjee, I mean, in his memory only we have so many things, and there is a famous, in fact, the football cup also in his memory. He was the first Indian AOC-NC Air Officer Commanding in Chief of the Indian Air Force. He was visiting Japan, Tokyo, and on 8th November 1960, He was having the dinner with one of his close friend in one of the restaurants in Tokyo. And in the lighter vein, fish was there, and a fish bone went inside his throat. Nobody on the spot could undertake a decision that whether to insert a knife in his trachea in the worst scenario, and we lost him. His dead body only arrived in India. Imagine the quantum of harm it may cause in such a elite category, to the such elite category of the people. We all must have seen that on day-to-day basis, the children playing with the attractive small pieces. Sometimes it is a stone, something a piece of the toy which has come out, and one puts inside the mouth. And traditionally, in fact, in the Hindu mythology, there are 5 indriyas, are the senses which are created: sight, hearing, taste, smell, and touch. And you got to feel when one of the senses is not working. Even the simple element like conjunctivitis, when our eyes are swollen, we are not able to see. To give an example, like I was doing a short course at IIM Ahmedabad, and they took us around to a institution run for the blinds, by the blinds, where one is put in a safely guarded environment, totally blind. The kind of distress one feels, uneasiness one feels. And similar situation remains when even we are not able to hear something. When wax has impacted or something has fallen over there. And in fact, in India and abroad also, many movies have been made. I don't know whether in my era, I mean, one famous movie is Koshish, famous late actor Sanjeev Kumar and Jaya Bachchan, Jaya Bhaduri, those days, are recently Khamoshi, and in fact, recent being Barfi, in younger generation would recall. So, I mean, these are the common problems which are so common. But if the timely actions are not undertaken, that sequence is disastrous. Like my young colleague Annapurna has come out with the data that in the children less than 1 year of the age, 7% of them they die. A lot of them they die, and in the 7% of the children less than 4 years of the age, it is the foreign body aspiration. So that is the quantum of harm we are talking about. And we are privileged to have Professor Mathur, who will be talking subsequently during the day. So do attend these sessions, ask the questions, ask the common problems which all of us are encountering, even in the health and wellness center, in the PHC, or even in tertiary care hospital. If you are in the emergency, you are all alone, and a child or even the adult comes with the choking or the body is cyanoed, what you are going to do. And prior to that, a very contemporary topic would be taken by Professor Sangeeta Sharma, which in fact talks about that how we can improve the quality of our prescriptions in a long way. So without much ado, I'm stopping over here, but I'm 100% sure, going by the the experience of the previous batches, that the things are going to be interesting. And let's try to learn that what are the things and how the things could be done at the peripheral level, at the every level of the facility. Once again, thank you very much for being with us, and let's hope that country has the better health outcomes, which will go a long way in strengthening the health system, whether it's the government or in the non-government or in the corporate. Thank you very much.
Thank you, sir, for setting up the introduction and also giving the examples, which shows the importance of treating the foreign body in the ear, nose, or any of the sense organs. Now I request Dr. Sangeeta ma'am to discuss on the quiz so that we can move to our next session after the quiz discussion on the quiz, ma'am.
Can you see my screen?
Yes, ma'am.
Yeah, it is visible.
Okay, good. Okay, I'll switch to full screen mode. Okay, thank you, NHSRC, Dr. Srivastava and Dr. Atul Kotwal for organizing this forum here, where we can get people from all over India, from all levels of healthcare. It's really very heartening to see that people from all over are joining us, and we will try to do as much possible to build their capacity. So that's how we keep selecting these topics also, where we feel that there are gap areas. Shall I do the quiz discussion? I think that I need to do that first, Anna, before I have to switch to okay. Okay, I'll quickly go through. We gave you a short quiz here. The idea of giving this quiz is to, what is the basic understanding, and whether those points were addressed during the sessions or not. I'll quickly take you through, what is the mixed group here. We have around 200 people in the room, and mostly are doctors, but quite a big 40% of our participants are nursing and from pharmacist background. Quality managers have also joined, and they all belong to different cadres. Here we have some few faculty members also here, CMOs and civil surgeons are there. Most of us, the people in the room, are from the government sector, but we do have participants from the corporate sector, private nursing homes, etc., and from field also. Uh, then I think the level of healthcare facility, we have people from all the levels of healthcare. Now let's get down to the questions. Which of the following is the best definition of a medication error? Most of you, two-thirds of you, have got this correctly. This is a preventable occurrence. Please remember that. Medication errors is not like adverse drug reaction which cannot be avoided. Medication errors are always preventable. So the other choice is where it is written unavoidable. Please, I think I will urge you, because if you look at the causation of these medication error, or the root cause of these errors, you will find that these could have been prevented. So and the next question was about, many a times, most of the time in fact, that we use these medicines for the management of the patients, and we have several formulations available in the country. Different dosage forms, formulations are available. Sometimes we do not understand how to take these medicines, and how each dosage forms are different from each other. So we must understand, when we use these medications, what is their proper use. And in this question, we had asked, which of the following tablets are formulated to prevent drug release in the stomach? Most of you have got this correct. Enteric coated tablets, they are required for prevention of drug release in the stomach. But sustained release tablets are also designed in a manner, although not completely, they are designed to release entire drug in the gut, but some of it may be released in stomach. But as the name suggests, the extended release, long acting, slow release, all of these preparations have been modified in a manner that they are released in the gut slowly. So but not necessarily in the stomach. Then film coated tablets and sugar coated tablets. The purpose of these tablets is, film coating is done for some of the tablets which are bitter, to avoid bad taste in the mouth. They are sugar coated or film coated, or when you don't want them to, properly be, you want them to be properly released in the body, film coating is done. So but they are very much released in the stomach. Now there are a lot of, every day we write prescriptions, and we use certain abbreviations. We write the strength and all that. The way we write these is very important for the medication safety point of view. Here was a case, a 43-year-old man who presented at PSC for insomnia. His practitioner decides a sleeping agent and writes a prescription. Diphenhydramine was written for him, one tablet by mouth, QHS, and he was asked to, pharmacy was asked to dispense 30 tablets. What error did he make in the prescription? Yes, around 40% of you have correctly said trailing zero. Many times we know that the prescriptions are not handled properly. They may be mutilated, they may be, spoiled. If you write a trailing zero here, 25.0, and if the prescription is not legible, then the person can get, this is unnecessary, and patient can get 10 times the higher dose. It has the danger of reading it as 250 milligram. And suppose you would say, who would give diphenhydramine in the dose of 250 milligram? But in our scenario, in our context here, we know a lot of people, get it from the pharmacy over the counter, or the pharmacist may not realize, or if the pharmacy or the nursing staff is being managed by students or who have not yet completed their training, they may make this mistake, and there is a danger that the patient may get 10 times the higher dose. So trailing zeros are not needed. Leading decimal, yes, it is needed. Some of you, I think, those who said 27, that leading decimal is, whenever you have to write a dose in 0.5 milligram, it should always be written 0.5 milligram, because like the danger in having it trailing zero, if you don't write a zero, leading decimal, then the patient can again get a 10 times the higher dose. Error prone abbreviation, yes, true. I think you must have not, QHS is a Latin abbreviation which has been used here. Then I'm not sure, why some people said no error was made. Perhaps, that's where we need to do some introspection and see, how patients interpret this, and how mistake can happen. Similarly here, I think I did not, okay, which error did the practitioner make when writing one tab by mouth, QHS? Again, QHS is a Latin abbreviation. You've said this rightly here, because when these Latin abbreviations were introduced, at that time prescriptions were written for the pharmacist, because they used to compound these medicines. Nowadays we are giving these prescriptions directly to the patient, and they need to read this prescription, or the pharmacy who is dispensing the, already those strips are ready. So these Latin abbreviations again are error prone, and if we do not know the correct answer interpretation, the patient may get wrong this thing. Now what does QHS mean? In, many of us may not even know what is the exact correct meaning of this mm, incorrect sense. The QHS is every night at bedtime. And if you want to know the correct Latin this thing, quark hora somni. Quark is every night. Hora somni, at bedtime. Somni is for sleeping. So we can, because patients cannot understand this. That's why we always say do not use Latin abbreviations here. Now again, this is interpret the following prescription. Take 1 to 2 tablets per POQ4H PRN pain. This is something that we understand, but the patients won't understand. And medications or the prescription is written for the patient. If they are not able to interpret this correctly, there are chances that they will take it wrongly and will be harmed. So PO is per oral here, Q stands for every 4 hours, PRN is every, now this is contradiction here. Every 4 hours, PRN. PRN is as and when required. So again, this goes wrong here. Now prescription also requires a lot of mathematical skills, and sometimes these decimals, as I told you earlier, are misinterpreted. So as far as possible, we should avoid writing dosage in decimal form. So at best it should be given in round figures, 1 milligram to 10 milligram. But here thyroxine, we know that it is given in microgram dosages. So avoid writing this in milligram, particularly if the prescription is illegible. Patient can get a wrong dose. And also sometimes conversion, we depend on the pharmacist to make this conversion. So he may not know, by mistake, if this can be converted. There is a 1 microgram, if you is 1 milligram is equal to 1,000 micrograms. Suppose if you multiply by 100 by mistake, and the patient will get 10 times the higher dose. And thyroxine is that way a high alert drug, and patient can have severe symptoms if high dose is given. So many of you have given correctly that 50 micrograms is the answer. Now another thing that you need to be very careful is when you write micrograms, mcg, it's always good to write either full micrograms or like mcg. But some of us use the mu sign for microgram, but that is discouraged, because this can be misinterpreted and patient may get milligrams, because our handwriting may not be good. So it's always better to write 50 micrograms if required here. Now then again, many times patients miss a dose, and everyone has a different notion. Some people think that you should take as soon as possible. Some people double the dose, or they may stop taking the medicine entirely because they have made few omissions, or they have not been able to comply with it. Certain drugs do require a good compliance, like anti-tubercular drugs, oral contraceptive pills, like these thyroxine and all that. Patients should be taking these medicines regularly. But if at all for some reason they are not able to take it, they should take it as soon as remember, but do not double the next dose, that may harm the patient. Then many a times it happens that you draw a medicine in your syringe, and somebody calls you, and you are not able to give this injection directly to the patient, and we ask our nursing assistants to do this. 67% of you have said correctly that this should be discarded. You make a fresh. The rule here is that the person who makes the injection will only go and give it. Never do this, that somebody else has drawn an injection and somebody else is giving. There may be patient, same name patient, there may be all those kinds of error happening. So it is always better to discard and redraw and give the injection. Now again, medication reconciliation is a process where you collect and compile, update and compare this information, of all about all the medicines being taken by the patient. This would include prescription drugs, over the counter drugs. This also includes vitamins, supplements, herbals that being taken. So I think we need to get this right. And medication reconciliation is one single intervention that can prevent lot of errors being happening to the patients. But hardly the reconciliation is done. Ideally it should be done daily. But I understand the patient load and the staffing position that we have in our hospitals, but at least we should make an attempt to do this reconciliation at 3 times: at the time of admission, at the time of transition of patient from one ward to another, to ICU, to OT, or coming back from ICU, OT, and at discharge. So these 3 points are very crucial, where there are chances that some medicines may get duplicated and some important medicines may get omitted. So reconciliation is something which does not need any extra intervention or resources, can be done by all of us at wherever we are working, and improve patient safety. Now this is a diabetic patient whose respiratory rate, heart rate are high, though saturation is okay, BP is low. Urine analysis is showing 3 plus ketones. The diabetic ketoacidosis patient, this can be life threatening. This ketoacidosis needs to be treated. So we need a long acting. Insulin is a high alert drug. It's a very good agent for controlling blood sugar. But if we do not use insulin properly, or if we give this in error, it can have a devastating effect on the patient. So we need ketoacidosis, and there are different types of insulins which are available. I'll be covering that in my presentation, so I can tell you at that time. We need to know the time of by the time taken to onset of action, because different insulins would have different. So only 52% have correctly answered this. Which are the long acting preparations, which are short acting, intermediate. So that knowledge is very much required to avoid any confusion and errors happening. Now, magnesium sulfate is another high alert drug, and toxicity has been reported, and the harm happens because of the magnesium sulfate. Respiratory depression is the major side effect with this. Then, this is a patient, diabetic patient. One of the very important adverse effect, or the complication that we see in the management of diabetes, is the hypoglycemia. Sometimes if you do not recognize the symptoms of hypoglycemia, harm happens. Particularly hypoglycemia, if it goes to level 3 hypoglycemia, patient can go into coma and death may happen. Now, route, by which route should we give insulin? Subcutaneous route is the preferred risk, and abdomen is the preferred site, for giving these injection. Although answers buttock, thigh, and arm can be given, but the preferred site is abdomen. Mild hypo. How do you treat mild hypoglycemia? I'll be talking about this. Now, one of the key features of credible standard treatment guideline is that it should be based on the local disease, coordinate with the programs, use fewest possible drugs. Uh, but the idea is not to target all the diseases. Then we have two questions on foreign body in ear, nose, and throat. I think Dr. Mathur will be deliberating on this, in his presentation. That will, let you know the correct answer. In the interest of time, I think I can, skip this for the moment so that we can hear him, get more time to hear him and sort out your. Then again, the last question was about universal distress signal characterizing the obstructive airway in a conscious adult. I think you only 34% of you got this correct. Rapid, these are not the universal distress signals. So we need to look into this, because they will not be able to speak. Dr. Srivastava was telling you this is, something which is an emergency that. Okay, now I can switch to my presentation. Okay, so now we know that prescribing is a complex task, requires diagnostic skills, requires knowledge about medicine, because most of the time it is the medicine that we use to control or cure a condition. And if we just now learned that there are many situations where medications can also harm. Besides, we need communication skills. We need to understand the follow up of this patient to draw a logical sequence from diagnosis to follow up. Prescription errors happen because there are a lot of drugs which are available in the market with the brand names. Several look-alike, sound-alike brand names are there, and then one letter difference in the brand name can patient can get a entirely a different composition. Particularly, you need to be very careful about LASR, OD, all those these names may be having another composition, and then similar brand name, same brand name being given to different pharmacologically different drugs is another very serious cause of concern for medication errors. About all these look-alike, sound-alike drugs. It is a requirement under NQAS or NABH that we need to identify this, because if you there are all chances that these there are several instances reported in the literature when these drugs were given in error and major harm happened to the patient. But do remember one more thing. Although I have shown all the injections here, there are look-alike, sound-alikes for the oral dosage forms as well. Most of the time when I go for the assessment, they had rightly identified look-alike, sound-alike drugs in the indoor department, but outdoor department where major oral dosage forms are there, they get neglected. So please identify these lists. And then, as I said in the quiz, there are a lot of error-prone abbreviations, symbols, and dose designations that we use in our prescription, and which have the chances of getting it misinterpreted. For example, we don't have much time to discuss each of the abbreviation here, but OD, this is something that we use every day. We mean once daily, but exactly the latent meaning of this is right eye. So a lot of us use this uh, uh, you know by mistake, unintentionally, but this can give rise to a problem. Similarly, Q1D and QID. Q1D is daily, QID is 4 times daily. So major errors have been reported because of this. Then now, because we are concerned about this, because these medicines are available over the counter, and anyone can get it. We already have seen the labeling and packaging issues which can cause errors. Then other contributing factors are illegible writing, incomplete knowledge of drug names, similar clinical use. And we know that these medicines are a double-edged swords. They have effect, but they have side effects too. So they are not like adverse drug reactions. These medication errors are preventable, whereas adverse drug reactions to some extent are inevitable. So that's the difference between adverse drug reactions and medication. While you cannot avoid adverse drug reactions to a great extent, but medication errors can be stopped from reaching the patient. Now let's see, what are the high alert medication. What do you mean by a high alert medications? These are not different medicines, but just because they have the high potential of causing harm when given in error. Like example, insulin is a very good drug. It's a lifesaver, changing drug for the type 1 diabetic patients. But if you give it in a wrong dose, very high dose insulin is given, then the patient can die of hypoglycemia. So the effect of giving it by mistake is very, very devastating. So we need to be careful about this. So that's why the name is high alert. It does not mean that the errors are more commonly with these medications, but when given in error, the outcome is very serious. So as a result, there are various additional costs associated. When we have to correct this harm, we may lose the patient, we may have to give antidotes or supportive treatment. So there is a greatest opportunity for improvement when we talk about high alert medications here. Now, some of these have been identified here, so we need to be doing a double checking of these high alert medicines. ISMP is the institute who have identified this. You may have add more drugs depending on the scope of your hospital. For example, magnesium sulfate can be added here because most of us are dealing with mother and child uh, diseases here. ANC clinic deliveries are being done, so you can add, but some of these have been listed here. So common risk factors associated because of giving these drugs in by mistake are because of the poorly written medication orders, incorrect dose, incorrect dilutions, confusion between the intramuscular, IV, intrathecal, epidural preparations, confusion between strengths of the same medication, ambiguous labeling on concentration and total volume of medications, wrong rate of administration, um, lookalike medicines, similar packaging and labeling. So, in this instance, this patient died after receiving a standard dose of 30 ml IV potassium chloride. This patient died because this potassium chloride was given as a bolus, whereas we all know that potassium chloride cannot be, never should be given as a bolus. It's always given as a slow infusion. So just the different rate of administration can also cause a sentinel event. And in another case, in this patient, 70-year-old patient, with a heart disease was taken for arthroscopy. He died on the table because of the severe arrhythmia, uh, because the order written for injection Lasix was misinterpreted. The doctor had written, give injection, IV Lasix IV 1 gram bolus every 2 minutes over 10 minutes, and the nursing staff interpreted this as she gave 5 injections every 2 minutes, so giving the total dose as 5 grams. So this patient died of severe hypokalemia. As you know, potassium is a high, potassium chloride is a high alert. Potassium in low dosages below 2.5 and above 6.5 can be lethal for the patient. And as I told you, the major medication safety challenge points are, patients in high risk situations, particularly those are elderly, very young, having other concomitant liver kidney disease, or those who are admitted in the ICU. There are more chances of these patients suffering from high harm because of the mistakes, or those who are receiving large number of medicines, particularly more than four. These are the patient at risk, and during transition of care, there are chances that there may be duplication or omission of an important. A lot of us are now these days using infusion pumps for delivering the some of these drugs, like dopamine, adrenaline, noradrenaline. Many of these drugs are given. Since we have a lot of nursing staff here, that is why I included this here today. We need to be very, very careful when we are feeding the dose here. There are chances, like when we are feeding some numbers on our mobile phone, instead of writing 2.5, many times we write 205. So that can give 100 times the higher dose here to the patient. So be careful, must always reset your infusion pumps, use smart infusion pumps, so that where you can feed the maximum dose, and particularly be careful when patients is on 2 or 3 drugs which are being given by the infusion pumps. When the line mixing happens, that can also cause error. So put a label on all the lines towards the distal end of the line, so that while injecting, many a times errors have been reported. A drug which was to be given by IV route was given intrathecal, like that. Errors have happened. You may sound, this how can this happen, but there are reports of these kind of errors. So many a times I see in my lab patients coming up, small children are getting, they are being advised dose in terms of teaspoons, but do not use teaspoon as the measure of the dose. You should know the ml, and you should know that the teaspoons are not to be used. Either you use the measuring caps coming with the bottle, or use the calibrated oral syringes without a needle to measure the dose exactly, and educate the patient accordingly. Teaspoon sizes vary, and I see patients coming in toxicity or with breakthrough seizures just because we haven't given advised the patient correctly. And then also know that you cannot split or crush uh, all oral dosage forms, especially sublingual, enteric coated, extended release should not be crushed. Many times it happens, patient is in unconscious, and we have to give the medicines by nasogastric tube. We crush it and give it. This can cause death of the patient. So when it comes to high alert medications, we must identify all of these high alert medications present in our formulary depending on our scope. But I want to caution here that don't make a very big list. Many times I've seen, many people put all the injections in the high alert list. The idea is that you have a list with you, so that you can control, check, and prevent harm happening because of this. But if you have a 100 or a 150 list of all these high alert drugs, the special attention to these drugs will not be made. Because idea is to improve the medication management, dose, maximum dose, antidote, so that staff dealing with this are well trained to handle if any error happens with this, so they can mitigate the harm, so that they can reduce the adverse effect of this. High alert medication identification is the primary this thing. And consider this at the time of making any new addition into your formulary, or you must review this at least once in a year, and make a list, prominently display at all the clinical care locations where these drugs would be used, and double verify these before dispensing and administration. Store in different locations in pharmacies and patient care units, especially the look-alike, sound-alike ones. And last one, this is a very important and very effective strategy, intervention to prevent harm from high alert drugs. Limit access to high alert medications. Control concentrated electrolyte solutions. For example, KCl is not required in inpatient units. You would need it only in ICUs or OTs. There's no point in keeping this drug in the IPD. Similarly, errors have been reported because of the confusion between V-curonium and Voveron. Voveron is a brand name for diclofenac, and V-curonium is a neuromuscular blocking agent. So there is no point in storing this V-curonium in IPD. You just reserve it for the outdoor OT, operation theaters only, where you can intubate the patient and have the antidotes also available. Look into this is a very effective strategy. And minimize this look-alike, sound-alike medication. Particularly, you need to be very careful. A drug, X drug, 250 milligram X is also available as 500 milligram and 1 gram packaging. All of these packages look similar, so try having less number of such pairs. Either go for 250 milligram or 500 milligram, depending on your scope and depending on your outdoor department, whether adults are coming or children are coming, like that. So that if you can reduce the number of look-alike pairs, there are chances that it will be error will be less common with this. And then separately store these pairs. High alert medications can be stored in red bins like this. While procuring, you can ask for these red bins, so that you don't have to put the stickers, auxiliary labels with all those uh, bins there. You can use warning labels, auxiliary labels like this. For potassium chloride, you can use dilute before use, shake well before using, especially the suspensions. If you don't give this instruction to the patient, they may take the upper part, which is less having less concentration. The bottom part may be concentrated, and the harm happens. And above and all that, a short and set, like this. If you can use these uh, sorters, that will help you in sorting these tablets. Then you use Tallman lettering. Dopamine, dobutamine sound alike, so you can use DOP, and DOBUT, so that that these are different drugs. And have monitor these patients often before and after administration, and keep antidotes and resuscitation equipments in wards ready for this. Do not use abbreviations, especially when you are prescribing high alert medications. If a small error in interpretation or reading can ruin the life. I have already discussed the use of naked decimal, trailing zero, liquid preparations. So let's today, I have got not all, there are number of high alert medications, but keeping the profile of the participants today, I think we can talk about insulin, oxytocin, magnesium sulfate, sedative, anticoagulants. These are the drugs where we need to improve our processes, and we can improve patient safety. And as I was telling you about insulins, there are many different preparations. So all of them become look-alike, sound alike medicines, which have variable onset and duration of action available. If you look at this, there are 5 or 6 different types of insulin which are available in market. These are all color coded. You can see the cap colors are there. These color coding is being done to avoid confusion. So please look for these color codes. If you look at the different insulins here, the rapid insulin, it has the rapid onset of action. The duration of action is also very, it is quickly, it declines over the period. So understand the difference between rapid and short acting uh, insulins. Intermediate, long term is to, it rises slowly but stays there for a long time. So they are intended for effect over 12 hours, 24 hours. So some of these type 2 patients need these long acting insulin. So knowledge about different preparations which are available, their onset of action, their duration of action is very important. And also errors happen because of the confusion between units and the insulin syringe, and how this insulin is administered, technique, the site, how do you inject. These are also important when it comes to insulins. There are different types of insulin syringes available. Do pay attention. There are U40, U100, U500. So U40 stands for 40 units of insulin per ml, whereas 100 U100 is 100 units of insulin per ml. So if you are not cognizant of it, error may happen. So, and you must understand the syringe that you are using. How much units will it be carrying. So zero point 0.3 ml syringes are for doses under 30 units of insulin. 0.5 ml syringes are of 30 to 50. 1 ml syringes are used for doses more than 50 units of insulin. So many times error happen if we do not educate our patients between difference between the mls and the units. And also errors happen when patient was in the hospital. You were giving uh, short acting insulins, regular insulins here, but when you discharge, they need to be converted, they need to be put on analog insulin. So conversion also becomes an important issue here. So with insulin, you need to also educate the patient. Besides checking the insulin type, concentration, educate the patient that they should coordinate meals and insulin administration. And when writing insulin, never use handwritten U to abbreviate units, because this U could look like 0 or 4, and the patient may get a higher dose. And monitor patients for signs and symptoms of hypoglycemia. So I have seen, we put the patient on insulin, but don't educate them on recognition about symptoms of hypoglycemia, because this hypoglycemia could be life threatening. And there are several reasons for having this hypoglycemia with insulin. Either because this is we have given in overdose, or the food was not taken. Some days we may just indulge in increased physical activity or excessive alcohol intake, food malabsorption, so poor injection technique. All of this can give rise to hypoglycemia. So we must recognize the severity. There are three levels of hypoglycemia. Level 1 is less than 70. When the sugar drops down below 70, it is considered mild because there are autonomic symptoms. Patient is conscious, can management, do self management. So for these patients, the rule is that you give 15 grams of readily absorbable carbohydrate, and wait for 15 minutes. And if the patient's sugar level does not rise, you can repeat another 15 grams and wait for 15 minutes. That's how. Or then ask the patient to take a regular snack, so that the hypoglycemia does not happen again. Now, what do you give, when I say readily assimilable carbohydrate is, many times patients take chocolate or aerated drinks. Those are not preferred. Juice or glucose tablets, glucose biscuits are the ones which should be given. If nothing is available, patient can take 1 spoon of carbohydrate, chini, which is available everywhere. So this is how you treat the mild ones. Then if the level 2 is when it falls below 54. In addition to autonomic symptoms, patient can have glycopenic symptoms, confusion, weakness, all those symptoms would. At this stage, you have to give glucose by parenteral route 25% or 50%, 50 to 100 ml, should be infused rapidly. If patient is conscious, you can try oral glucose, but in hospital you would need this 25% to 50%. Severe is when it falls below 40, patient becomes unconscious, so it needs urgent assistance. It potentially life threatening. At this stage, injection glucagon is required. So it's very important that you differentiate between hypoglycemia and diabetic ketoacidosis. If you can, well, good enough, you can treat accordingly. But sometimes the patient may not, whenever you are in doubt, you don't have a blood sugar or other facility available, there is a confusion between hypoglycemia and ketoacidosis, or on the side of hypoglycemia, give 25% glucose. On recovery, identify the cause and re-educate the patient, because hypoglycemia particularly is life threatening. High sugar for some time may not be immediately threatening the life, but hypoglycemia can. So re-education is very important. And I told you about the potassium chloride. You need to, this is a very narrow range. 3.5 to 5 is the range, and if levels fall below 3.5, you have to be really very careful. And if similarly levels above 6.5 is are again need to be so. But must remember that never administer potassium chloride by IV push or a bolus. This can be fatal. And you have to restrict, hyperkalemia. You need to do the treatment and all that. The staff must be aware, but be aware of the pseudo hyperkalemia also. Pseudo, as you mean, is the false report of hyperkalemia. This can happen because the sample was not drawn properly, tourniquet was applied for a long time, and patient exercised immediately before drawing blood sample because you could not see the vein, and the blood sample uh, was not transported as soon as possible, or it was drawn from the infusion site. So all these can, so beware of all these things. Now, oxytocin is another high alert drug that we use every day. This is used in pregnancy, labor, and purpurium. We all know about the indications of oxytocin. But what are the problems with the use of oxytocin? It can have side effects on the maternal side, fetal side. So their greatest risk is that it can lead to uterine hyperstimulation, rupture, water intoxication, and hypotension, and it can lead to fetal hypoxia and fetal death if the oxytocin is not used properly. So these errors happen because the wrong dose was given. Those of you who are using computerized order entry systems, in that, usually when you enter first three letters, a drug name pops up on the screen. And if you, and because a lot of brand name drugs are available, if you use PIT here, pitocin is for oxytocin, but pitressin is a vasopressin, and oxy can be misinterpreted as oxycontin, oxycodone. So be aware of that you don't select a wrong drug, or when you use this oxytocin when contraindicated. For example, elective inductions prior to 39 complete weeks, you need to be really very careful. Then administration errors happen very commonly with oxytocin, and second important concern is delays in responding to oxytocin induced complications. Uterine tachycystoles is, you need to be really very much prepared. Then look-alike vials, pitocin and ondansetron vials look alike. So those hospitals who deal with both these drugs need to be very careful. So the oxytocin administration procedures is a challenging one. While when you prepare and label these, many of the labor units, because they have shortage of staff, or the patients delivering numbers are more, many of us pre-prepare oxytocin. So be careful that the sterility is maintained, and the preparation is also. Then infusion pump or IV line mix-ups happen, because this also needs to be given in a graded infusion rate. Confusions are there many times. There is a confusion between units of measure, rate, and volume of oxytocin. So be very careful when you are dealing with oxytocin. Many times, inadvertently, by mistake, bolus doses are administered from leftover drug in the tubing. Earlier was given oxytocin infusion was given, infusion was over, now you put something else in that IV line. So the IV line, which was full of oxytocin, this can be delivered and can cause harm. And especially when then last step is the handoffs during transition of care. If we don't communicate properly, or if we don't document the dosages response to oxytocin, this can lead to. So the policies that you employ, standard order sets, everyone knows when you are using in antepartum, in postpartum, standardized clinical approach is used, and use uniform mixed preparation unit wide. Don't use different preparations. So 30 units, for example, in 500 milligram of milliliter of ringersled. So how much will it be created? So how much will it be delivered by the infusion? So use the standard ones, standard dosing protocols, prophylactic doses. So label and trace all lines, especially just above the injection port, closest to the patient and just above the pump. And limit verbal orders with these. Discontinued, discard discontinued bags and change the oxytocin tubing to avoid those bolus dosages. And use uniform patterns for maternal and fetal monitoring for notification. Document all these. Communicate the electronic heart fetal monitoring and timely response. And what this timely response means should be communicated to all the members who are providing care to the patient. Now next is IV magnesium sulfate. We need to use this. There are many indications for this, and especially this is used in eclampsia, and now used for neuroprotection of the fetus in the management of preterm labor. We are concerned about this because it is a narrow therapeutic window requiring careful attention. So an overdose can cause respiratory and neurological suppression. So the problem with this magnesium sulfate is that it is expressed in grams, in milligrams, millimoles, or weight by volume. So calculation and administration errors can happen. So most commonly preferred is 20% weight by volume. So you must know what is the equivalence of this and how much dose is given. Never use 50% magnesium sulfate. 20% is the maximum strength for IV use. Use uniform packaging and all that. So key element is that you remove the magnesium line from the IV port. Again, the bolus can be delivered later if you don't change it. And standardized monitor if you have that facility, to monitor the serum magnesium level and have this independently verified so that the dose is not given wrongly. Again, warfarin is another high alert drug used for various indications. The challenges with warfarin are again the same: narrow therapeutic range, many interactions. This is one drug which has several drug interactions. So any patient who is on warfarin expect some drug interaction, expect some drug food interaction. And here medication reconciliation becomes even more important, because the patient may be taking many OTC drugs, herbal drugs, so they which may interact with warfarin, and it again has a complex dosing, so therefore requires frequent monitoring, and patient compliance is required. So again, with warfarin, limit the number of tablet strengths, use the standard protocols, manage supratherapeutic INRs. INR monitoring is very important. And how will you hold warfarin pre-operatively? When will you resume warfarin post-operatively? All these things should be clearly documented and known to all the staff members. Patient education here is very critical. All these educational programs should be implemented. Now, third one is heparin. Again, this is available in many different strengths, and you can imagine when given in error, either it can lead to thrombosis events or bleeding event. So both of these can be life threatening. So be careful with the heparin. One good intervention with heparin is that you limit the strength available. Either you go for either of the strength depending on the scope of your hospital and the common indication for which you are using. So either you get 1000 unit per ml or 5000 unit per ml to avoid having mistakes with heparin. Another mistake happens because heparin is also made for flushing the lines, or the pre filled syringes are also now available. So use them carefully. and weight based heparin protocols should be followed. Wristbands should be given when you transfer them. Then sedatives are another life threatening if they are given in error. So again, limit the availability of sedatives. Monitor these patients, especially the children, during pre-op, operatives, and post-op procedures. Have resuscitation equipment and the antidote for reversal available in your health facility. Flumazenil is the antidote which is used. It should be readily available at the point of care. Monitor these patients for respiratory depression, for exaggerated sedation, because that is the usual cause of death in these patients. Now, one more very effective strategy that we need to look into is provide adequate lighting when the patient are admitted in the hospital, especially when they go to the toilet, because these are the patients on sedatives. They are dizzy at times when they get up at night, and because of the poor lighting, or because they slip in the bathroom, they may have fractures and other sentinel events. So look into this. So I think I have dealt with this. The all of these things are handled in the standard treatment guidelines. These are disease oriented manuals, and I told you that um, same, I don't know whether you could follow that same standard for all levels. Standard treatment guidelines tell you that the treatment would not change just because the patient has come to a super specialty hospital, or a tertiary care hospital, or a primary care. The treatment remains the same. It is the referral criteria depending on the available infrastructure, personnel, drugs, monitoring facility, that you decide that this patient will be handled at a primary care, or a secondary care, or a tertiary care. A simple example is dehydration, diarrhea patient. The management would differ depending on the degree of dehydration, but that does not mean that the mild diarrhea patient coming to tertiary care directly will be getting intravenous drugs, or injections, antibiotics, like that. The mild diarrhea remains, approach to mild diarrhea remains the same, whether the patient lands up at a primary or a tertiary care. Just because primary would not have facility to handle severe dehydration, so that becomes the referral criteria for sending patient to a higher level. So that's the only difference, otherwise there are no differences. And these guidelines, they are not these strict laws, but it is always better. There are many now news courts have started taking cognizance of it. These guidelines apply to average patients. Atypical patients, you can modify the treatment, but then you should have enough reasons why are you not giving a standard of care. Even for follow up, standard of care is required, particularly for stroke, when the patients are on antimicrobials. So all of these things are answered if you follow a standard treatment guidelines. The features are, that these guidelines give you the introduction to the disease, briefly describe the salient features, which includes the presenting signs and symptoms, the investigations which are needed to confirm the diagnosis, and how will you do the monitoring based on clinical features and the laboratory. And the most important part is the treatment part, and it also includes the non pharmacological treatment. treatment is not only with the medication. Many a times we need to supplement, complement pharmacological treatment, or some patient may be truly managed only on the non pharmacological basis. That's very important. Then assessment of response to therapy is very important. We are very good at starting these drugs, and we keep on escalating if the patient is not responding, so we add another drug, we may increase the dose, like that. But many a times, since we do not know how to do the assessment of the response, we may escalate it more than required, or earlier than it was required. For example, a freshly diagnosed hypertensive patient has come to you, and a week later comes back again to you, and BP is still high. So the general tendency is to increase the dose of the antihypertensive here. But we know from the pharmacological knowledge here that it takes at least 3 weeks to 4 weeks for antihypertensives to reach its peak response. So any increase in dose before that can lead to hypotension. Patient may later come with hypotension. That is the side effect of these medicines. Similarly, if you have put the patient on oral hypoglycemics, if you increase the dose or you add another hypoglycemic agent here, the patient may later have hypoglycemic events, or maybe remaining on unnecessary medicines. Then lastly is about the patient education section, which is very much required. I think I'll go, Dr. Mathur must be waiting. Patient education remains a very, very important part of it, especially when you talk about high alert medicines. You may say something, you may have explained these to patient, but how the patient's understanding is, it may be entirely different. I think this depicts very, we have designed the pathway like this, but we find that the users experience the other way. Unless you talk to the patients, we will not come to know. So listening to the patient, educating them, is a very, very important part of the safe use of these medications. You must educate the patients about do's and don'ts, when to stop, when not to stop, when to come back in emergency, when not to worry about. Many a times patients get alarmed unnecessarily also. For example, you put the patient on iron therapy, and the patient may get alarmed if he sees black stools, and he may stop the therapy. Similarly, for urinary tract infections, you may give urinary analgesic pyridium. This is gives rise to orange discoloration, and patient may get worried, I've started getting blood in my urine. So these are the things that you need to educate your patient. And when it comes to prescribing, you need to comply with the requirements, rules, standards. So you need to be doing this. STG help us in providing the expert consensus, so that you can, you need not worry about the treatment part. Treatment is given in the standard treatment guideline. All you need to do is to concentrate on the diagnosis, and you can utilize your limited time if you make the correct diagnosis. The treatment part, the success, likelihood of success with the treatment would increase. And this will help if you follow standard treatment guidelines. This helps the practitioners, especially those living at PHCs, CSCs. They can upgrade their skills, and supply also improves, because then that these are the things that you need, so you can focus on the supply and improve on this. So I think with this I stop. I over step this, but it happens, when you have to do the quiz and this session together, it happens. So next session would be on 15th of April. That's the third Saturday, and we'll be discussing about prescription safety in pregnancy and lactation, and management of burns is the topic. I think I'll stop here. We have Dr. Mathur here with us. we can. Yes, welcome, Dr. Mathur, for this session. And I think he is a very, very accomplished specialist ENT. And I was told that you were the one who started, this program and the endoscopy. Before that, you were the first one, especially in the Delhi state, to introduce these programs. Annapurna, can you introduce Dr. Mathur?
Sure, ma'am. Sure, ma'am. Dr. Neeraj Narayan Mathur is an ENT surgeon and professor and head of the Amrita Institute of Medical Sciences and Amrita Hospital, Faridabad. He has 40 plus years of experience. He has a distinction of heading in medical colleges as a principal and director at Vardhaman Mahavir Medical College, Safdarjung Hospital, and Lady Hardinge Medical College and Hospitals for nearly 6 years. He has been awarded several fellowships, including Graham Fraser Fellowship in Cochlear Implantates at Royal National ENT Hospital, London. Also, Commonwealth Fellowship in Pediatric Otolaryngology at Great Ormond Saint for Sick Children in London. Also, WHO Fellowship at House Ear Institute, Los Angeles. He has added the several research projects and published over 90 research papers and presented and participated in over the 500 national conferences and chaired the many scientific sessions. He also been engaged by Ministry of Health and Family Welfare as an expert in the development of MBBS curriculum based on the competencies. I welcome you, sir. Sir is going to take a session on foreign body in ear, nose, and throat. Over to you, sir. Thank you, sir.
Thank you very much, Dr. Annapurna, Dr. Sangeeta Sharma, and Dr. Srivastav for introducing me and for asking me to be sharing my views on this topic with you and for inviting me for this wonderful session, which I just heard of Dr. Sangeeta Sharma. It was so exhaustive and it was so nice. And we clinicians also, I was relating myself with that so many mistakes that can happen by the clinician in writing the prescription. As very rightly pointed out by Dr. Srivastava and highlighted, our first Chief of Air Staff, Subrato Mukherjee, died of inhalation of a foreign body in Japan. And his body was flown. It was so tragic that it happened. And probably nobody could revive him from that incident which happened in a restaurant. And you would be amazed that now there is a legislation in most of the states in the United States that every restaurant in some of the states will have the clear instructions as to what to do and what is a Himmlich maneuver. And those states, some of the states in the United States will also have a trained personnel in the restaurant to manage such condition if it ever occurs. So this is the learning from there and or from many other incidences that we should know how to manage the foreign bodies as a first aid. We'll go to that little later, but let me start that 7 orifices are there for the otolaryngologists to deal, out of which 5 are with otolaryngologists, 7 out of 5. And children are very curious, and their siblings or their nursery chums to put some foreign bodies into their siblings or into their friends' nose, ear, or throat. And in adults, sometimes accidental and sometimes when they are mentally deranged, they can inhale the foreign body or can put the foreign body into one of the orifices. Now, some of the foreign bodies can be very simple to manage and they will not cause any harm till that they reach the doctor. But some foreign bodies are life-threatening, especially if the foreign body is in the larynx. It is life-threatening. It will induce choking. And many a times the person is not able to make to reach a doctor. But if the foreign body is in the ear or is in the nose, then it may remain unnoticed for some time. And it is not necessary that there will be uh, any sort of a threat to the life. Now, as you can see in this picture, there are two foreign bodies. One is the stick and other is a small bead with a hole in between. And they are in the ear. And now such foreign bodies can remain there for some time and can be removed by a doctor. But while removing it, you can damage the whole ear. So it is very important that these foreign bodies in the ear are removed as perfectly as possible without damaging any structure which is nearby. And that can happen only if you see the down picture on the downside of this picture, a microscope, the operating microscope that we use. So all these foreign bodies have to be removed under strict vision, and that vision is usually very well given by the latest operating microscopes or the endoscopes. And microscope has got the advantage of both the hands being free, and so uh, you can perfectly pick that foreign body and remove it with the different forceps. So there are very different foreign bodies which can be put into the ear, like cotton wool, insects, beads, paper toys, broken matchsticks, and erasers. They remain asymptomatic for a long time, but can induce pain or discharge by the otitis externa. But there are foreign bodies like some insects which can go into the ear and they cause a lot of annoying discomfort by their movement and the noise. So if there is a living foreign body which is put into the ear or goes into the ear, then first our attempt should be to kill it with the oil, maybe the lukewarm oil or just the oil, and the insect will drown in that oil. Even in the water, that insect will drown, and you can remove it. Or you can, if the foreign body is irregular or the graspable objects, then you can remove it with the crocodile forceps. Never put syringing or water into the foreign body, which is vegetable foreign body, because it will swell up and then it will clog the whole ear canal. Buttons and the batteries sometimes are put inside the nose and the ear, and even in the throat and into the larynx. They go into the trachea, and they have the tendency to leak, and that is alkali, and that causes a lot of coagulative and necrosis all around, and all the structures nearby get damaged. Uh, Round, hard, and smooth foreign bodies can be syringed out and or can be removed, but the non-graspable ones can be hooked, and usually they need to be removed under general anesthesia. Commonly impacted foreign bodies, you have to make cavity around, and so that they can come out, and they require some drilling with a micro drill. So, uh, but all the foreign bodies have to be removed such a way that you do not remove, damage the tympanic membrane or the ossicles behind, because if you damage it, then it is not pardonable. I mean, these foreign bodies have to be removed without any further, damage which can occur because of the foreign body. The nose. Sometimes children especially put different things in the nose, and it can be chalk, it can be rubber, or it can be anything. And this is the instrument which is there down below, the eustachian catheter. This is very commonly used and the most useful small instrument to remove all the foreign bodies. You just go behind the foreign body and roll the foreign body along the floor of the nose, and it comes out. In almost all the circumstances, it will come out. So you don't have to actually see the foreign body where it is extending. You can just roll it along the floor by putting this eustachian catheter behind it. And this is usually done under no anesthesia or just a spray of xylocaine into the nostril. If the child comes to you with unilateral discharge of the nose, from the nose, then you can almost be certain that this is a foreign body. So any unilateral discharge or vestibulitis, one side only, then always think of the foreign body. And so unilateral discharge and the battery and corrosive we have just discussed, if it is there, don't put any water there and just try to remove it as fast as possible because it will cause a lot of necrosis around. Sometimes if the foreign body remains in the nose for a long time, it forms a rhinolith. And this is formed by the mucin layer, which gets layered onto that foreign body, and then it becomes little tough, and it forms, there is calcification, and the whole structure becomes one big body of calcified foreign body, which is called the rhinolith, and they need to be removed and may require general anesthesia for its removal because it is entangled all over the places. Ingested foreign bodies are very common. They are swallowed into the pharynx and the esophagus. They can be inhaled into the larynx and the tracheobronchial tree. And they are major public health problems, especially in the children who are between ages of 2 to 5, 2 to 4. They are very curious to put everything which comes into the mouth. And even the smaller children who are less than 2 years old and they have just started crawling, and they put everything into their mouth, whatever comes. And one of the things which fascinates them most is the peanut. It should be rather written on every peanut that keep it away from children. There had been days in Kalavati Saran Children's Hospital when I was working that we have removed not one, not two, not three, but 10 children with a peanut in one night. So the problem is that enormous in winter months that the peanuts come and you have to remove them. So some swallowed foreign body can be very simple, like coin, and they are removable easily. But there can be some with the wires, and they go and get entangled, and their part of the foreign body can become extramural, and then it becomes a little difficult to remove them because the part of it is outside the esophagus of the pharynx, and there are vessels around. And if you try to remove them, then if it has already pierced the vessel, then the surgeon can be in problem. But usually you will find these foreign bodies on the X-rays, and these are the two X-rays that are done in most of the cases. One is the AP view, and the other is the lateral, which will actually tell you how is the foreign body lying. And so there is a coin here. Now, just by looking at this X-ray, I cannot be very sure that it is in the trachea or in the esophagus. Although such a coin will usually be in the esophagus because in the trachea it has to go through the larynx, and the coin will not pass in this position through the larynx. But you have to confirm it by doing an X-ray lateral view to see if the air shadow is in front and the coin is behind, to be very sure that now this coin is at the cricopharyngeal. It is below the cricopharyngeal level. It is in the esophagus. And so these foreign bodies need to be removed before they cause any complication. And the foreign bodies which are in the esophagus, the pharynx, are usually removed with a rigid esophagoscopy, or if it is very high up placed at the level of the cricopharynx, then it can be removed just with the esophageal speculum or the hypopharyngoscope. But they are usually done with a rigid esophagoscope or the rigid hypopharyngoscope. The most dreaded foreign body is the laryngeal foreign body, which gives rise to sudden choking. And the Himmlisch maneuver, I'll just elaborate on it. And every one of us should know the Himmlisch maneuver, even if we are not non-medical. As we know, we should know the resuscitative measures that need to be given. We should also learn the Himmlisch maneuver. So Himmlisch maneuver, direct laryngoscopy, and the tracheostomy have got the role in patients who have got the laryngeal foreign body. Now, the Himmlisch maneuver is what? Himmlisch maneuver is something like this. You stand behind, if the patient is an adult, then you can just stand behind. He will not be able to stand. So you will be holding him. He will be falling, but you will be still try to hold him and somehow get him into this position that he is standing. And because he will be choking, most probably he was sitting before this, or even if he was standing and eating, he would be just falling down. So most probably he has fallen down, or he's sitting in a chair and almost half unconscious. You make him stand and go behind him and put your arms onto his abdomen, above the navel and below the chest, rib cage. So in the upper abdomen, above the umbilicus, and give a very tight thrust onto it towards you, so that the diaphragm gets up and the foreign body which is there in the larynx just comes out. There is a certain pressure created. It should be very tight and very, very solid uh, push just at the upper part of the abdomen. And this usually helps. It will not help in every case, but it will help in most of the cases. If somehow the patient is pregnant, then you can give it and up in the lower part of the chest and do this Himmlisch maneuver. But most of the patients will be children, or even infants, or very small children. So there you will not be able to stand behind them, and this will not be possible. So what you do is put the child in such a position that he is resting upside down and in a prone position on one of your thighs, and then you give a thrust and tap his chest very hard many times from back. So you just tap the back very tightly, once, twice, or thrice, and the child coughs out the foreign body. If that is not possible, then you may give the child the same Himmlisch maneuver, but in this position, and give the Himmlisch maneuver with two fingers rather than with the whole palm. Or else you give uh, just if the child is big, then you can make the position like what is depicted in figure C. Or if the child is still bigger, then you can make him stand on a small chair, and so that he comes to your level, and then give the Himmlisch maneuver. This Himmlisch maneuver should be learned by one and all, because you don't know who will be required to do it when. And because when the foreign body is in the larynx, then there is hardly any time, and you have to act before the anoxia settles in, and uh, and the foreign body has to be removed. There will be no time in the laryngeal foreign body for the patient to reach the caregiver or the doctor. Very rarely, if the foreign body is very small and it is at the larynx, and it is giving like partial choking, so that the patient is able to breathe also still, then it is possible that the patient may reach a doctor with a laryngeal foreign body. Otherwise, the patient will either die, or he will be helped with the Himmlisch maneuver only. So we must learn the Himmlisch maneuver. One thing that we have to know is that our airway is small. If there is in a small airway, even if there is slight edema, it will give rise to exponential increase in the resistance. So if the airway is a 4 millimeter and if it becomes 2 millimeter, by just 2 millimeter edema, then the, the airway resistance increases 16 times. Whereas in the 8 millimeter tube, if the same amount of edema occurs, the airway resistance increases 3 times. So, meaning thereby, small children, even small edema will increase the airway resistance many times. So, therefore, it is very important that in children you act very fast, and because they will be losing the diameter of the airway very quickly. So, when the child comes to you, you will see the signs of recession, intercostal recession, the below the Z3 sternum, there is abdominal recession, there is intercostal recession. The muscles in adults, the muscles of the neck will be working, and the child will be crying. And with a cry, what sort of a cry it is, you will be able to make out what sort of a problem the child could be having. Any child who comes to the and he's able to reach the hospital, first thing in the waiting room, uh, these things should be available. And before the child is taken to the theater for the definitive treatment, uh, you must oxygenate, or the patient, even adult, you must oxygenate. You must put the monitors for the oximetric analysis, the different probes. You must give the steroids and also start adrenaline nebulization. This drug is a wonderful drug, and when with to nebulize with, and it decreases the edema. It makes you buy time. By the time you are arranging the theater or calling the doctor or the nurse, it will take about half an hour for everything to be arranged. In that half an hour, these four things must be there. So all the nurses must know the Heimlich maneuver. All the nurses and the doctors must know how to handle the patient who has come with the stridor into their clinic or into their emergency, as to and what to give till the time the ENT or a surgeon is called. So till the time the ENT arrives or till the time any surgeon arrives, oxygenate, put the monitor, the oximetric analysis, start the steroids, and give the ADR nebulization. So this is what the emergency setup should be. All these things are essential. Without this, you cannot call emergency an emergency setup. And nowadays, we have all the emergencies with these setups, but there was time that many of these articles were missing. So all the emergencies must have good stock of dexamethasone. All the emergencies must have good stock of epinephrine, and the nebulizer, and the oxygen, and the hood, and the oximetric probe, and the monitor. Without this, emergency is no emergency. So the tracheobronchial body, choking, coughing, and wheezing. This is a triad of symptoms with which the child will or the adult will come. Whenever the foreign body will go, it will first choke the person. Means you can't breathe. You can't breathe in, you can't breathe out. So you just, and this is choke. If the person is lucky, he is gone down into the trachea and the bronchus, it is lucky sign. It is good that it has gone down. It will fetch time. Tracheal foreign body is an emergency, but it's not that big an emergency. Bronchial foreign body is an emergency, but it's not that big a foreign emergency as the laryngeal foreign body is. So if it has gone down, if the choking has subsided, then there will be body reaction. Body reaction will be what? Body reaction will be if the foreign body is inside, body will start throwing it out. And so you will have cough. So the patient starts having cough and he tries to have violent cough so that the foreign body comes out. Sometimes it does, sometimes it doesn't. And then there will be respiratory distress and the wheeze. So that will happen. So this is the triad of symptoms. If somebody comes with a choking, coughing, and wheeze, we are almost certain that it could be a foreign body. Always take the history. If somebody has seen the child or the person eating or inhaling something, that one positive history will take you. There are two arms in the treatment when the patient comes with the stridor, acute stridor. One arm is looking towards the infective pathologies, epiglottitis, acute epiglottitis, acute laryngobronchitis, and things like that. The other arm is foreign body. So the treatment is entirely different in the two arms. And if we have the history of the foreign body inhalation, then we don't look into the other arm. So we are very certain and no time is wasted. Sometimes these foreign bodies can become silent later on. If it was a small, say, peanut, very small peanut, first they were choking, coughing, and squeeze, but later on, once it has gone into one of the bronchus, small bronchus, then it may become silent and remain silent for some time. So it could be silent foreign body. I have taken out foreign bodies which have remained there for 10 years. I'll show one picture. So some of the metallic foreign bodies from the bronchus can be removed, which have remained for years, and they are silent. They give rise to symptoms after years when there is some bleeding suddenly because of erosion of that around the foreign body, and there is a bleeding. And then there can be chest complications. The chest complications can be picked up with X-ray findings. Now, these X-rays, if the patient comes to you with the choking and wheezing and he's brought within few minutes or few hours, X-ray chest will be normal. Except if it is a metallic foreign body, you will find some metallic foreign body there. Otherwise, if the symptom is the history of the symptoms and signs is only for hours, and you find chest X-ray with positive findings like collapse or something, then it is definitely not a foreign body. So in a few hours history or few minutes history, the chest X-ray should be normal. So this is, but later on, there will be valve mechanism, bivalve mechanism. The air may be able to go in, but not be able to leak out. And so there will be emphysema. As you can see here on the right side, there is an emphysema, and the whole mediastinum is shifted to the left. So, so there is a very big role of the X-ray chest. Now, the foreign bodies have to be removed with the instruments, and if the place is not well equipped for removal of these foreign bodies, then it should not be tried also. Just make the patient fit enough with your first aid and with the oxygenation, with the nebulization and things like that, for him to reach at a place where the correct equipment is there. Because if you try with some equipment which is not correct or which is inadequate, then you will messing up. You will be making some foreign body which was irremovable, and the patient you will be losing. And unnecessary anesthesia and unnecessary manipulation will make the patient's condition worse. These foreign bodies have to be removed as quickly as possible. I mean, quickly means once you start giving anesthesia and remove it, that procedure should be very quick. The patient cannot be under anesthesia for a long time and with you manipulating all the time. So that procedure part should be very quick, and that will happen only when you are equipped properly and you have all the sizes of the bronchoscope, all the forceps, everything with you. Because one bronchoscope, you may find it's not going in. You will require a smaller size. You may require some different telescope. So you should have the whole range of telescopes and the bronchoscopes with you for it to have a good chance of removing the foreign body. 99% of the removal of the foreign body is equipment based. The surgeon is important, definitely. His clinical skills are important. The doctor is important, but more important than the surgeon and the doctor is the equipment. So the equipment should be complete. If the equipment is not good, even a good surgeon will not be able to remove it. So equipment is very much essential. The first foreign body from the airway was removed by viaduct with the first bronchotomy. Then there was a man called Gustav Killian, he was a German, and many instruments are named after him, who removed the foreign body from through the larynx from the bronchus. So he was the first one to go from above and remove the foreign body from the bronchus. Then there was an American, Chevalier Jackson, with whom we have all the names of all the bronchoscopes. All bronchoscopes are Jackson bronchoscopes or the Negus instruments. This Negus was a British and Jackson was American almost at the same time, and they designed and they improved upon the versions of the different modern day bronchoscopes. Modern day bronchoscopes are ventilating bronchoscopes, and I'll show you what ventilating bronchoscope is. So if we go by the epidemiology, 80% of the patients with the foreign bodies of the airway will be pediatric, and they will be mostly less than 3 years old, 1 to 3 years old. And most of them will have the foreign body in the right bronchus. Some of them will have in the left bronchus. 80 to 90% will have in the bronchus. 2 to 12% will have in the larynx, and 11% of them, and some of them will have in the bronchus and the larynx both. And many of, very few of them, only 11% of them will have the radiopaque foreign body. Most of the time, the foreign body will be something like peanut or a groundnut or some vegetative foreign body, which will not be seen on the X-ray. So these are the different foreign bodies, and as I told you, the most common in our country, and especially in the North India, in the winter months. Come November, December, and January, and all the ENTs are busy removing the peanuts from the bronchus. So this is the most common foreign body. In West, it is not peanut. They have the hazelnuts, and they have some different types of nuts which are coated with some oil. Once the nut is coated with the oil, it becomes even worse. It causes a lot of reaction around, and it is difficult to remove. So these are all nuts which are there inside the bronchus in children, small children, who try to take that foreign body in a very typical way. What happens is that if the child has got upper respiratory infection and he is unattended, he has got a foreign body in his hand. A typical story is like this: foreign body in a hand of a 2.5-year-old child, unattended, and he tries to put it, or even smaller, maybe foreign body in a hand of a 1-year-old child, unattended, puts that peanut in his mouth. He's having a URI. He sneezes. During the sneeze, the inhalation part of the sneeze, the foreign body goes in. Child doesn't have the molars, and child doesn't have the teeth. The whole peanut in one piece goes in. Most of the time, you'll find the complete peanut. It is complete peanut in a small children. In little bigger children, you'll find pieces of foreign bodies. But in small children, the whole piece goes in. And this is very typical history, that the sneeze actually is the culprit finally, so to say. The inhalation part of the sneeze is the culprit, so to say. Although the culprit is putting the foreign body into the mouth also, but then the sneeze, because then even the child doesn't have any control. Even the adult will have no control once the sneeze is there. anything in the mouth will go in. So this is very typical of the triad. Triad we have already talked about. So we have our algorithm that if we give marks, and if the marks out of 100 are 40, then we go ahead and do the bronchoscopy. So 40 marks are given to witness aspirating. If the mother says that I have seen, or the sibling says that I have seen this child was playing and he put something in his mouth, and after that he just started doing this, I'll go and do the bronchoscopy straight away without asking any question. But if that story is not clear, then we give 20 marks to dyspnea, 10 marks to the wheezing or the stridor, 10 marks to the cough, 10 marks to the 20 marks to the oscillatory findings, radiological findings 20 marks, radiological finding not matching the duration of history 10 marks, and fever 5 marks. So we have done this algorithm for us. And if anybody scores 40, go ahead and do the bronchoscopy. Now, as we say, told the larynx, trachea, and the bronchi will cause different sort of symptoms, and the laryngeal will cause more of sudden deaths and a complete airway obstruction, whereas the trachea will cause airway obstruction but not complete, and the child or the person will, the patient will be able to reach you most of the time, and the bronchi will be having cough, unilateral wheeze in 80% of the cases. So there can be valve formation, bypass valve formation, and I'll show you in another picture that sometimes the air ingress and the egress both is possible. So there will be partial obstruction. Here there will not much of an emphysema. But if the air can go in but cannot come out, then there will be obstructive emphysema. And if the air cannot go in and neither can come out, then there will be obstructive atelectasis. So whether the atelectasis is forming or the obstructive emphysema is forming, or it is the normal chest which you will be seeing, will be all dependent on how the ball wall here is working. So the foreign body and the edema around will decide as to what will be the picture in the X-ray. So this we have already discussed as to how the stages of the aspiration occur. And we have also discussed about the X-ray chest findings. Very rarely you would be required to do the computerized tomography. Very, very rarely. When the foreign body is of a long-standing nature and it is not possible to make any diagnosis and you are not getting any clue, then or the foreign body has gone beyond very much into the tertiary bronchus, and you are not sure where it is, or it has become extramural, it has gone beyond the bronchi, then you may do the computerized tomography. Virtual bronchoscopy can also be done in some of the very, very, very rare cases. Usually it's not required, or the fluoroscopy. This was one of the nails that we took out, and as you can see, this child, when he was seen at another place before he came to us, he had the foreign body like this. Half of it was outside the larynx, half of it was in the larynx and below. But by the time he reached us, the nail became like this, and it is very funny because the bronchus is the primary bronchus is not this much aligned like this. Primary bronchus is aligned like that, but it was like this because half of it was in trachea pushed on this side, and it was somehow maintaining. It came into this position, and we removed it. It was a nail, and it was a rusted nail. Such foreign bodies can be there for a long time, and we have removed one nail, not this one, but some other nail, which was there for 10 years, even in the bronchus. So this is one of the X-rays that you can see that on the inspiratory, when there is an inspiration, you find that there is an emphysema here, but it is not very, very different from the other side. The foreign body is on the right side. But when the expiration occurs, so this side, the whole air has come out, but here nothing could come out. So this becomes more obvious. So you should do the X-ray both in the inspiratory phase and the expiratory phase to make it very obvious as to what the condition is. Virtual foreign body bronchoscopy usually is not required, but it is of academic interest that you can do the virtual bronchoscopy also and see the foreign body. Now, all the time, the question arises whether to do the rigid bronchoscopy or the flexible bronchoscopy. The gold standard is the rigid bronchoscopy, and we must try to remove the foreign body with the rigid bronchoscope. Very few foreign bodies will be able to be removed by the flexible bronchoscope also. But the child is sick and he's gasping for air. If the rigid bronchoscopy and the surgeon is not available, then and you have the flexible bronchoscope because you are a pediatrician, then it is possible that you may try. But you will not be able to remove all the foreign bodies in that case. And the child who's gasping may not be a good candidate for you to try the flexible bronchoscope under local anesthesia. So most of the time, it is very safe. And if the person is reached at a correct place to do everything under general anesthesia with a rigid bronchoscope. Now, these are the bronchoscope and the laryngoscope that you must have all seen, or you can see. This is the laryngoscope, and these were the earlier laryngoscope with the lighting system like this. Nowadays, we have got better laryngoscopes, and which have got the inbuilt fiber optic lighting system and much better illumination. And these are the bronchoscopes. You can see these are the bronchoscopic tubes. Bronchoscopic tubes differ from the esophagoscopic tube that they have got the vents. Vents is for the ventilation of other bronchus or other primary bronchus or the secondary bronchus. And on the ventilating bronchoscope, you have got different tubes coming out. Now, this tube is for connecting your anesthesia machine onto and giving the patient the oxygenation. This is for putting the prismatic light reflector in, that is for giving the illumination. This is for the jet ventilation, and this is for you to see through and put your instruments in and do the suction and remove the foreign body or whatever you want to do. So these are the ventilating bronchoscopes. Earlier, the bronchoscopes used to be like that. They were not ventilating in a sense that you had to do it under apnea. And once the anesthetist used to give the oxygenation, and then he will come out and remove the mask. And then you go in and the patient is in apnea and you remove the foreign body or you do the bronchoscopy. So those were non-ventilating bronchoscopes and requiring different other techniques for giving the anesthesia. Because the main challenge when you remove the foreign body from the bronchus or the trachea is that how do you share the airway between you and the anesthetist? Anesthetist requires the airway to give his anesthesia, and you require the airway to remove the foreign body. And both of us are sharing the airway. So the different techniques are there to, to handle such situation. And this situation is best handled with using the bronchoscopes, which are ventilating. Now, all the nurses and all the doctors, especially the nurses who are working with the team of an ENT, should know that what are the different size of the bronchoscopes which are needed. So the size of the bronchoscopes which are needed are 2.5 to 6, and that will cover almost all the patients who would require the bronchoscopy. So have the different sizes of 0.5 number more, starting from 2.5, and these are the different instruments through which the bronchoscope, the foreign bodies are removed. These are the different forceps. Now, the most common forceps used is of this shape. It is called the peanut forceps, and this is the most common forceps which is required. But we should have all the type of forces because foreign bodies are different. Also, whenever the patient comes with a foreign body, ask the parent or whosoever has come or the patient to show a replica of that foreign body, whether you have ingested, the patient has ingested or inhaled. A replica of a foreign body, unless it is a peanut, will be very useful. And you must try your forceps onto that replica and do that maneuver before getting into the patient and try to see whether your forceps holds that foreign body or not and how you'll remove it. So you can do the exercise just outside by having that foreign body. And because there can be, if especially the foreign body is irregular, then you will have a lot of knowledge as to how you will be removing the foreign body without injuring the tissue around. So especially if this is a irregular foreign body like mother's earring and or a necklace. Children are very fond of putting these things inside. Many times we remove earrings, and they have got the, that needle sort of a thing, and or many times we remove the whistle. Now some whistles have got 3 parts, some whistles have got 4 parts. So it's very important if you have the whistle, uh, you know that how many parts you are going to remove. So the vessel has got a papery thin plastic, and then a tube, and the tube is divided into two, and then another tube which is holding this divided tube together. So usually you have 3 parts. Sometimes you have 4 parts. And how you'll remove, unless you know that how many parts you want to remove, you'll remove half the foreign body and half will remain inside. So it's very important that you get the replica of the foreign body. Ask them to get the replica of the foreign body so that you are better informed. And this is the rigid bronchoscope I have already described as to what are the different parts of it. So these days we have got very good optical system, and earlier days we used to see, when I was a resident, we used to see from here and do all the bronchoscopies. Nowadays, I need not have a 6x6 vision even. This instrument does all the work for me. It's beautiful telescope, Hopkins rod. And the Hopkins rod, whether it is bronchoscopy, esophagoscopy, colonoscopy, sigmoidoscopy, arthroscopy, whichever scopy, you use rigid telescopes, and that is called the Hopkins rod. In bronchoscopy and esophagoscopy also, you use these rigid telescopes along with bronchoscopy or the telescopic tube, so that you have the camera attached here, so you can see in a large screen. And the things have become much easier for the residents these days. The removal of the foreign body has not remained that fascinating as it used to be 30-40 years before, because we used to see through the small tube and remove the foreign body with a lot of tactile inputs coming from the hand. These days, you can see it on the large screen, and everyone can see in the room and give his inputs also. So things have changed, but good for the patient. Yeah. So this is the flexible bronchoscope, and you must have all seen. They are the same esophagoscope or the bronchoscope, but they are flexible. The problem with the flexible bronchoscope is that the tube is very small, thin, and the instruments that you can pass are very thin. There is the anesthesia cannot be given, and because the instruments are very thin, all the foreign bodies cannot be grasped with that. So it's not possible to remove all types of foreign bodies with the flexible ones. And the time is very important. The time which is lost is very crucial. So it is best to give best try in the first attempt. These are the different instruments that you would require. You require the laryngoscope, you require the Hopkins rod, 0 degree, you require the rigid ventilating bronchoscopes, you require the video, and you require the rigid laryngeal and tracheal suctions. You require the flexible suction catheters to fit in through the side ports of the bronchoscope. You require the optical forceps. You require non-optical forceps. You require Fogarty catheter, ureteral baskets, and the flexible bronchoscope. All these things are required. So there are some contraindications of doing the bronchoscopy, but they are very few. if the foreign body is there, then there is no choice but to remove it, whatever may be the contraindication. Positioning of the patient is, I'll skip that because this is basically for the ENT surgeon to know. And the anesthesia also, we have already discussed. So the position of the patient is sniffing position. The patient is lying spine. Try to protect the teeth, especially in children. The teeth will become another foreign body if they are, little loose teeth, because the child is growing. So he will have a lot of loose teeth. Insertion of the bronchoscope is again a technique that is for the ENTs to know. In this forum, it's not that important whether you know or not of the insertion of the bronchoscope. So these are the foreign bodies that you will find. And in one of the bronchus, as you can see, it is a foreign body. The other bronchus is free, and there is edema around. Hemostasis is very important. So the nurses should make the adrenaline available, and the doctor will ask for the different concentration of adrenaline and the plagets to be put around the foreign body for the hemostasis achievement. And it is very important for the OT staff to be prepared with adrenaline solutions. Common errors which can occur is failing to carefully check equipment before procedure. And you find that the equipment is missing, something is missing, and you can see the foreign body, but you can't remove it because that forceps is not there. Grasping hastily and breaking the foreign body into pieces is another mistake. Dislodgement of the foreign body, you are taking out the foreign body and suddenly at the level of the larynx, you drop it, and then it becomes a laryngeal foreign body. Not checking the residual and additional foreign bodies is another problem. You see, so you may not be able to, you may miss one, or there could be two foreign bodies, and you remove one, and one still remains. Too long a duration of manipulation without proper ventilation. Extramural portion not recognized, and the manipulation is done. Sometimes the foreign body is sharp, and it is outside the wall of bronchus or of the esophagus, and you try to remove it, and that causes a problem. Overriding the foreign body. Sometimes you don't see the foreign body. What you have done is your bronchoscope or the esophagoscope has gone over it, and you are down below, and you are searching for the foreign body without realizing that you have passed through the foreign body. So these are the common mistakes. Flexible foreign bodies I've already discussed. You must always do the repeat foreign bronchoscopy in case the symptoms persist or there is an edema. So to summarize, rigid bronchoscopy is the first line therapy for all suspected cases. An experienced team is needed. Experience with available equipment is what is needed. Ensure the availability of appropriate size bronchoscopes and forceps. A duplicate foreign body is very helpful for the planning. Appropriate instruments based on the type of the foreign body is important. And check bronchoscopy after removal to look for additional foreign bodies and residual foreign body is very important. Thank you very much for kind listening. If there is any question, I will be happy to answer. Thank you.
Thank you, Dr. Mathur, for such a lucid explanation, and you made it so simple. I was, thinking it's such a big topic, and how would you, explain it in terms of do's and don'ts in such a short time. I think the participants also must have had the same feelings, and I can see the comments in the chat box. If there are any questions, you can put these in the chat box.
Thank you very much.
Are there any questions? I think, for those who are at the district level or the CSC, all of us see these cases anywhere they may come. And I hope you've got back, you are now confident, what are the do's and don'ts, when you first see these patients in your, practice there. If there are any questions, I think it was too very clear. May I ask you one question?
Yeah, please.
These more severe one where the bronchoscopy is needed and all that, referral would be made anyway. But things like that, foreign body in the nose or ears, particularly if it is in the nose and it's a child, the child is particularly non-cooperative. And you can see this, how many attempts should be made, and whether the child should be sedated or not, the positioning of the child. Could you just explain
So the
that?
child is made, you usually, this will be the situation that the child is either held by mother, or if we have a nurse, trained nurse, then by nurse. The two legs of the child will be between the two legs of the nurse, and the child is made to sit on the nurse, and nurse with one hand will hold both the hands, and the other hand she will hold the head, and the child will be crying, and will be trying to move here and there, but with this position you are able to control for a second, and that 1 second is good enough for removing the foreign body. And usually it is done without much anesthesia. We spray it with the nose with the little xylocaine, and the eustachian catheter goes in, and foreign body is usually out in first attempt or the second attempt. You should not attempt more than that, because the child will start bleeding more than that from the nose, and there will be epistaxis. But usually in 80 to 90% of the cases, you'll be able to remove the foreign body with that. Those cases who are not being successful are put to sedation and taken to the theater, and with the endoscopic approach, the foreign body is removed.
Sir, another difficulties, sometimes the vegetable has been ingested,
Yeah.
and and we put water. You have amply discussed
Yeah.
this in your
So
presentation,
it will
and I
swell up.
think
Yeah.
yeah, it will swell up.
So
So it
the
should not.
yeah. So especially the peas and all, if they are put inside, and they will swell up, and uh, then the instrumentation has to be done, and for removal.
There is a question: why no sedation in nasal foreign body? Can you just repeat this once again? I
So
think.
because in all, see, the nose fortunately has got not much important structure in a sense, not many delicate structures around. So that way it is safe. Unlike ear, which has got very delicate structure behind. It has got a tympanic membrane which will get perforated. Nose fortunately doesn't have. So we can take chance in the nose, and that's why in most of the foreign bodies from the nose can be removed without the child getting into the general anesthesia, and just with the local spray and holding the child tightly. As I said, the position is very, it is described in most of the books, textbooks. People can see it, that both the legs of the child in between the two legs of the nurse, one hand of the nurse holding both the hands, and one hand holding the head, and tightly, and one go, and the foreign body most of the time comes out.
So sometimes that it has gone into the esophagus, and people as a first aid, make them to drink something or eat something. Is that a good practice or a bad practice?
Well, uh, drinking or not drinking will not make any difference. It is okay but drinking will not help in the foreign body to go down. But there is a group, I have not discussed corrosives. So that is also sort of a foreign body. So if the child has drunk an alkali or an acid, many times these corrosives are used in the body, in the houses, in cleaning as a detergent and things like that. And sometimes they are put in similar bottle as the water bottle. And by mistake, even adults sometimes, drink it. And by the time they realize that it is an acid, it has already gone down. And it is a terrible life thereafter. The acid, especially the alkali, produces a lot of necrosis around. And even the acid produces. So there lies the question of time, and not about the swallowing, but putting in the Ryle's tube or not putting in the Ryle's tube. Because if that patient comes to you very early, then we put in the Ryle's tube. We take a chance and put in the Ryle's tube, because that is the only time that we have to put in the Ryle's tube. Later than that, it will all be necrosed, and and you will not be able to put. It will go here and there. So if somebody has ingested alkali or acid, then that question of what is there of taking liquids or stopping taking liquids arises in those patients who have swallowed a corrosive. But if it is a foreign body, which is like a coin or fish bone or a bolus of meat, then it's okay. You can one can swallow water or anything, though it will not help in going down. Yes, the high roughage in a small foreign bodies like small fish bone is what is given. Anything which is a lot of fiber can be given, and most of the small fish bones will go down and will be okay. So this high roughage diet in the fish bone is very effective.
Sir, sometimes either button batteries, ingestion and their treatment is a session itself. Can you just give the tips for first aid if there is a history of button battery ingestion?
Button battery has to be removed quickly, whether it is in the nose, it is in the throat, it is in the esophagus, or it's in the trachea, wherever. Button battery is the worst foreign body because it's a time bomb. It is leaking every second. And if it is at one place, it is just a time bomb at one place, and it's concentrated necrosis at one place. So if it is moving, still it is little better. That at least it is not necrosed that area too much. But once it is stuck for few seconds or few minutes at one place, then it becomes very very urgently removed, need of removing that foreign body. So it has to be removed.
There was a question about universal sign of gasping. Can you just explain to the participants?
That choking and
the
so
universal sign that
yeah. So when there is a laryngeal foreign body, the first sign will be choking. So that you can't breathe in, you can't breathe out. You are like this. Now that the foreign body is in the larynx. Once it goes down, then you'll be then it will be better. It will be better. There will be stridor, but it will be better. At least, but even the stridor cannot be produced if it is in the larynx, because the air cannot go in, cannot come out. So even the stridor is not possible. So it is, you're just stuck. So that is choking.
What about rapid heavy breathing, violent choking, violent thrashing of the arms? Are they also indicative
Yeah,
of
they
this?
are indicating if the foreign body has gone down in the trachea, then there will be labored breathing and distress, and that labored breathing is still better. The patient is giving you time, so that is still better. You have few minutes or maybe half an hour or 1 hour to take him to the nearest place and get him bronchoscoped. So once the respiration starts, even if it is stridulous, it's a good sign that at least the patient is breathing and he can be moved. But choking requires nothing but the Heimlich maneuver. Then because it will be too late by the time he reaches the hospital, unless it has happened in the theater itself. So choking is is the laryngeal foreign body, and the only thing that you can do is the Heimlich maneuver, or if he is an ENT surgeon or a very trained person, trying to put the hand inside and see if he can see the foreign body to help taking it out. But those things will be see how you react to immediate foreign emergency. An emergency also that is immediate is dependent on the skill of a person, the circumstances that you are in, and there is no guideline as to what you should do or what you should not do. You will do whatever is best at that particular time and how much you know. So uh, the knowledge that we can teach to the general public is only the Heimlich maneuver. We can't teach putting in the hand, and unless you can see the foreign body and you can somehow hang around, go around the foreign body and take it out, which will be possible by the ENT, but may not be possible by others.
Sir, there is a question, that if somebody has put organophosphorus poison into the ears, what do we do?
No, it has got. You will tackle it as any other foreign body. It doesn't matter. Organophosphorus part of it will not cause any problem.
But you need to remove this as early as possible. So,
Yeah, you
to
need to.
prevent absorption of this from because it can get absorbed from the mucous membrane.
No, but it will not free. We are not expecting the tympanic membrane to be damaged. We are expecting everything to be fine. So it will remain. It will, even if it remains there, it's okay.
And it won't be a large amount, also to
Yeah.
have a significant absorption from the skin.
Yeah, nothing gets absorbed from the ear unless the tympanic membrane is damaged, which we can presume it is not.
Okay, there is one more question about spherical foreign body removal is very difficult. What are best instruments and forceps for this?
So spherical foreign bodies, depending on where they are, if it is in the ear, then there are hooks available. If it is a bead and there is a hole in between, then there are different forceps available. If it is in the bronchus, then there is a Dormier's basket. Even otherwise, there are baskets available which can go. The basket can go below that foreign body, and you can open that basket, and it comes out in that. So there are different forceps and the baskets and the instruments available for dealing with the circular foreign bodies, spherical foreign bodies.
I think there's one last question now. This is about adrenaline dose. How do you prepare swabs, and what should be the dose for nebulization?
So the nebulization will be 1 ampoule of adrenaline. Nebulize it completely with the similar amount of saline. So 1 ml is there, or 2 ml is there, and the 2 ml of saline, and nebulize it completely. You can repeat it after 10 minutes if the child is not able to get benefit. So nebulization, usually 1 or 2 ampoules, maximum 2 ampoules, we can nebulize in about 15-20 minutes.
So how do you prepare those soaks? Are they readily available or you need to prepare them?
Uh, uh, uh,
Adrenaline
sorry.
soaks.
Adenine swabs, these are patties used in the bronchoscopy. They are as any other patty, like neuro patties, we call them, and they are marketed. They are available. Or if it is not there, then we use the ribbon gauze and make your own patties.
The formula for strength, that remains the same as you prepare for 1 in
Yeah,
1,000.
usually when it is for the local application, where if there is bleeding, then they are used as it is. I mean, no dilution. The completes are this thing, but we keep the amount in mind. We note down so that we don't overdose the patient.
I think with this, all the questions, queries have been sorted out, and your presentation itself was very clear. I think they will all be in position to handle this, and they would know when to refer. Especially the laryngeal ones, where the time is crucial, so that we don't make them unnecessarily wait or make unsuccessful attempts at the level. Timely referral is needed. I think with this, I'm once again would like to thank you and sparing time from your busy schedule. I know
Thank
you
you very
have,
much.
I know you have to reschedule
No,
your other pre-committed
no,
program.
no,
But for us, this is a fixed day and time.
no.
So, and most of the attendants, participants here are returning participants. They attend all of our sessions, so beforehand they know this, and they get this their time calendar blocked for this. And the announcements are also made much in advance, so that was our difficulty. I apologize for
Oh,
that.
no, not at all, not at all,
Uh,
not at all.
Thank you once
Thank you very
again.
much. Thank
Thank
you.
you.
Thank you.
I think for the participants, the session is over. You have got the post test link with you now. Please fill it up. It is important that you do the post test as well, for us to issue a certificate of participation. And also, it gets us insights into the, how have we covered the sessions. I know, within 2 hours, discussing two very important topics, one on the safety part and the standard treatment, and a special topic like this is difficult. I think it's already 5:40 today, but most of you don't mind sitting over. uh, I think please complete the post test link. If you have clicked it, you can do it even if we end the program, or else we can keep the session on for a few more minutes.
Okay, thank you, ma'am. Thank you, sir. On behalf of NHSRC and Quality Patient Division, I thank the both speakers, Dr. Sangeeta Sharma and Dr. N.N. Mathur, sir, for taking the time to conduct this session and sharing your valuable treatment protocols, even on the foreign body aspiration from the stage of aspiration to the removal of it. And this session will be uploaded in the YouTube. You can access it through the YouTube link, which I have shared already in the chat box. You can access it after 4 days. And our next STG lecture series will be scheduled on 18th of April 2023 on the
No,
topic of
no, it
burns.
is not 18th, Annapurna. It is third Saturday, falls on 15th.
15th of April. It's a 15th of April. It's a 15th of April on the topic of the burns. And to get a certificate of participation, please attend pre and post test. As I always say this, because later we are getting so many mails that, so ma'am, we didn't get the certificate, as it is auto generated who has attended pre and post test by timely. So automatically it will be get generated and it will be come to your mail ID around 3 to 4 days. but many of your mail IDs which is registered we are getting wrong, and or else because of the storage box is filled in your mailbox, it is reverting us continuously as we are trying to resend it again and again, but it is reverting to us. If you have a full of storage inbox in your mail ID, please make sure that there is a space to get the certificate from our side. Thank you all the participants for your cooperation till 7th session lecture series, and hope we are again left with another 5 lecture series to complete this complete online lecture series for a year lecture series. Now you want to say anything?
Annapurna, besides burns, we will be discussing, medication safety in pregnancy and lactation.
Okay, okay. The technical session के साथ we have, as ma'am
Both
said,
the ones too.
prescription on the lactation and the pregnancy. So we have these 2 sessions for the next April 15th of the 2023. Thank you one and all.
Okay, thank you, Annapurna, for hosting
Thank you, ma'am.
and giving us back end support. It's a great support.
It's my pleasure, ma'am.
Okay.
Thank you.
Thank you.